Well, good evening, everyone. Dr. Scott Stoll from the Plant Nutrition Project, and this evening I am joined by an amazing group of colleagues, extraordinary physicians, and trusted friends, Dr. Kim Williams, Dr. Margarete Ezinwa, Dr. Dexter Shurney, Dr. David Bowman, and Dr. Columbus Batiste, to really have an organic conversation around a very important topic that is near and dear to my heart and should be near and dear to all of our hearts, especially in the lifestyle medicine space, because lifestyle medicine is the solution for health inequalities, health disparities around the world. And so, I really want to focus our conversation this evening. First is awareness, helping all of us to understand the depth, the reach, and the scope of the problem, the roots of the problem, systemically, where did this come from, which helps us to better organize solutions. And I want to focus at least the last third of our evening on proactive solutions that all of us can start with today. And the reason I've invited these guests and friends tonight is because they're all actively involved in reaching their communities. Margarete is working internationally to solve the problem, and so they have tremendous experience that they can share with us about reaching into these communities to begin resolving the injustice and helping to bring solutions to people in great need. And just to set the tone and kind of context of our evening, in lifestyle medicine, we often say that it's not our genes, but our lifestyle that determines our health destiny. But for many people, their zip code or geography perhaps is more important because it shapes their lifestyle choices, which ultimately drives their health or disease. It's really where people live, are born, work, play, socialize, worship. And the research shows that, up to 60% of someone's health may be determined by their geography, because it dramatically ultimately limits their lifestyle options and choices. For example, in the city of Chicago, individuals residing in the Loop, the heart of downtown Chicago, Kim knows this well, have an average life expectancy of about 83 years. But for residents living in the nearby neighborhood of Washington Park, it's just 3 train stops away from downtown Chicago, the average lifespan is only 69 years. The gap in life expectancy is the equivalent of the US and Honduras. And that should shock all of us. So a couple of other just brief data points, I think, that kind of bring this into clarity. I want to focus this through the right lens. In developing countries, they account for about 99% of the maternal deaths in the world. For example, women living in Chad have a lifetime risk of maternal death of about 1 in 16, compared to women living in Sweden with a lifetime risk of less than 1 in 10,000. Today, 87% of the premature deaths due to non-communicable diseases occur in low and middle-income countries. Life expectancy varies by at least 34 years between countries. In low-income countries, the average life expectancy is 62 years, while high-income countries today, it's 81 years. A child born in Sierra Leone can expect to live for 50 years, while a child born in Japan will live to 84 years. In low-income, low-access areas, 50% of the population has limited access to supermarkets and grocery stores. These food swamps that are present in low-income communities have a greater density of fast food restaurants and convenience stores that serve as the primary food resource for this group of people. Diet-related disparities mirror the increased proportion of cardiovascular disease, and Kim's going to take us deep on that. In these low-resource settings, healthcare costs for non-communicable diseases quickly drain household resources, driving many families into poverty. And the exorbitant costs of non-communicable diseases are forcing millions of people into poverty annually and stifling development. And as we all know, COVID-19 has elevated this ever-present issue of limited investment in low and moderate income communities and rural communities, evidenced by the increased rate of moderate to severe COVID and death in these communities. So we have, a significant issue, health disparities, which is really defined as the unequal distribution of critical health and social resources. It's a tremendous challenge, and there have been, attempts at multifaceted approaches, but it still remains a problem, and it has not been solved yet. I believe physicians are a key and critical resource that have not been effectively mobilized to address this issue. But with awareness, with empowerment, with connection and community, I believe that the physician community, especially the lifestyle medicine physician community, can begin to actively work in and around their communities in the United States and abroad to become a social center and an ambassador and a force for change. And so, in that context, I'd like to begin our conversation. And I think what I'd like to do is just maybe ask each of you, we'll start with Dr. Margarete, just in your own words and from your passion and your place of compassion, if you could just outline the scope of the problem, what you've seen, and we'll just kind of work down the line and just help, set the right context for the conversation this evening. So Margarete, please take it away.
Thank you. Well, first and foremost, thank you all for being here. And thank you, Dr. Scott Stoll and Tom and everybody from the Plant Nutrition Project, because this is such an important conversation that we're having. And I think that now is the perfect time to be able to talk about it, because I really feel that we're coming to a tip point where we will be able to get the nutrition and lifestyle resources to the people who need it the most, but have least access at the moment. So as we're coming up to 7.9 billion people on Earth, that is over a third actually who are currently undernourished. And there are two burdens. Often there's both malnourishment and what we can call calorie rich but micronutrient poor nourishment. So although they may have plenty of calories to the point of obesity, they are very undernourished because of it being poor quality food and poor quality food choices. I also do hear in your introduction, the other big thing is that many of these populations are struggling in poverty, and I'm speaking from a global perspective, struggling in poverty and with a double burden of infectious disease and non-communicable disease. So at the same time as we have people dying from non-communicable disease and lifestyle-related diseases, we also, at the same time, are struggling with the infectious disease as well. And with that double burden of disease and poor infrastructure, poor health systems, and poor options, that is really, I think, where we can have the greatest impact and where it is needed the most. So I think it's incredibly important. And yes, I know that I speak internationally on an international level, but right here where I work in San Bernardino in Southern California, many of the same issues are rearing their head. And so I appreciate what you said and completely believe as well that we can have an impact locally and an impact globally. And I would say to everybody on this call, never to underestimate the power that you have to make small change that will be propagated. So thank you.
Wonderful. Thank you, Margarete. And just a note, if you have questions, at the bottom of the window is a Q&A bubble, and you can put questions in there for us. We'll take questions maybe at the top of the hour. So please feel free to send us your questions. Kim, how about if we go to you next?
Well, I really appreciate you putting this on and having this kind of conversation. As I look at my practice on the south side and west side of Chicago, growing up on the south side, and I look at the healthcare disparities. So you talked about the life expectancy, but we also have, and being a cardiologist, it's very much, we're all very much aware that the cardiovascular mortality is so much higher in the African-American community. So our shortening of our life expectancy isn't, gangs and drugs and the like. It really is cardiovascular as well. And part and parcel of that is the burden of kidney disease. And we can blame all of the ApoL1 gene, which is an issue in the African-American community. But what we really have with this is a very impressive lack of understanding of how important it is to control the blood pressure. And this isn't just the patients. This is actually the practitioners as well. And so what we end up with is 13% of the population and 35% of the dialysis patients. So why does it even a cardiologist care about that? It's because dialysis patients don't die of kidney disease, they die of heart disease. It really is an accelerant. It's throwing fuel on the fire that's are pre-existing and really worsening our outcomes, whether it's heart failure, which we have an excessive burden for, or heart attack, stroke, as well as the coronary artery disease, and that accumulates when you have the terrible biochemical milieu of kidney failure. Okay, so what can we do about it? Because you really want to talk about some solutions. And I would say that our studies at Rush have shown that if you give people the right food, their risk factors will melt away. And that is something that we've done, but you do it as an intervention. It sounds really good. If you can afford to feed people forever, it's great. But we did it for 5 weeks. And, after the end of that 5 weeks with a tremendous biochemical improvement, albeit, by the way, the 5 weeks of vegan food that we sent them, the motivation was giving up something for Lent because we did it in a Southside Christian church. And, there was a history of, giving up fried chicken or giving up soda pop or heaven forbid, cigarettes if a church person was still smoking. But they would do something for Lent to improve their health. And trying to get that message out there and do a vegan intervention actually did work. The problem is it wasn't sustained. And that's because we have 4 major issues that I would just point out quickly. Number one, we don't have an understanding, even though we try to impart it and show the person how the 10 pounds left gave them a 43% decrease in their insulin level. Okay. And therefore they were so much better off metabolically. The cholesterol went down and blood pressure went down and the like. You have to give people more than just biochemistry and advice. You have to have practical ways of getting food in their hands that's it's really healthy and going to improve their outcomes. That's going to be combated by my second issue, and that is that we market mortality. That actually is the name of our manuscript that analyzed television commercials. And unfortunately, our African-American population actually really does substantially market bad food. There's a grading system for food. Is it going to be helpful or harmful? And we have guidelines out there talking about saturated fat, sodium, processed meat, animal protein. We have cholesterol. We have guidelines out there, but they're not adhered to by people who market those kinds of things. And I should add that we will have the socioeconomic differences make our population less financially capable and less employed even. And it turns out that the poorer you are, there's almost a linear relationship between how much television watching there is, an inverse linear relationship between television watching and income. And so that is such a strong effect that all of those television commercials, particularly for fast food, the putting of a lot of fast food restaurants in the poorer areas. And I know it's because they're being drawn there because that's where the money is, but they are participating in a cycle that ruins the health. The next one, of course, is the congressional funding. That is, we actually have congressional funding that goes to making some substances cheaper than others. And so it's the high fructose corn syrup, for example, and many other examples are out there that make the least expense for the worst food. And so we have, people talk about food deserts and other people say, well, they don't exist. Maybe we don't have food deserts, but we certainly have a food apartheid. Okay. And that was a term I learned in Louisville, where I'm actually going to move in a few weeks to become chair of medicine. And they're very interested in health equity and trying to solve these problems. But if I had to make one last point, and I'm sure we'll have more to talk about, it would be to get everyone to understand that food controls everything. And if anybody on the call, which is probably most of us, have not heard of the food effects on the microbiome, it's something that we all should be looking at. And when you're eating a bad diet, you have a sort of a dysfunctional microbiome. It creates a variety of diseases, including bad outcomes from COVID. And all of the cardiovascular risk and neurologic diseases, they're all related to having a bad microbiome. And the best way to clean it up is a whole food, plant-based diet. That message is not getting out there, not fast enough. It's just buried in the medical literature. But it's very actionable, and people can change their microbiome in a matter of weeks. So those would be my big four, and I would hope that we could actually have some action points and go to Congress and say, pay attention to your, have the guts to go vegan, because your gut is determining all the diseases on all our healthcare expenditures. And when I see a patient who says, I really can't do that, I have to do what I'm doing, I have to question their patriotism, because we're drowning in healthcare, funding crises, and it's only going to get worse.
Wonderful. Thank you, Kim. Fantastic. We'll come back to those four in a minute. Dexter.
Yes. Well, I also want to echo the sentiment of others that this is a great conversation, and thanks for doing this, Scott. Couple of things I would say is, and as a lot of you know, I've spent a lot of my professional career on the payer side, in particular with large employers, global employers. And so to your earlier opening comments about the cost impact, when you're an employer, you feel this on your bottom line. I worked for a manufacturer, and our healthcare costs were going up by tens of millions every year. And the question always was, well, how many more of what we make and manufacture do we have to sell just to cover the cost of this? And unfortunately, those costs were going up in these chronic lifestyle related conditions. And so it's right in the face. And so that's where I've been really looking at this. And when you start talking about solutions, when we put lifestyle medicine programs into play, we could actually see some results. Now, and we can go back to why some of these didn't stay in place and why they were not sustainable for organizations. But we would see the effect. And again, these were global organizations, so we could try these on individuals of different ethnicities, different races, and we got the same impact. So the human body is the human body, and it responds to good lifestyle. And so, it sort of dispels all this issue about, genes, and genes are your destiny. The other thing is, we live in a society where the majority will soon become the minority, and the minority is soon going to become the majority. And so we're going to see more and more of these healthcare costs rise for employers, and it affects the bottom line. We all end up paying for it. And so that's something that I've been involved in. And so this is really important. And the way that we've turned some of this around has been with the food. The food is key to this. The other thing I would say, and involve some of the work that I'm involved with now, is that if you look at the blue zones, and I wanted to just say this because of your point earlier, Scott, where we were talking about the economic issues and underserved or communities that were really third world communities, and the disparities that we see there. There's an interesting thing about the blue zones, and for those that don't know, these are areas around the world where people live to be well into their hundreds, much more frequently, and they don't have any health issues. And they're, it started off as looking for a fountain of youth in the world, and it ended up what they found was, there are some longevity places, are actually abnormalities, you might say, and they found some common traits among those people. And there are 5 places in the world, where this is happening. And what's interesting is that 3 of those 5 areas are below the poverty level for the world. So I wouldn't call them as third world, but they're not affluent areas of the world, and yet this is where this longevity and better life is occurring. So I just wanted to put that out there, that it's not entirely an economic issue. It's really a lifestyle issue in terms of how you're able to live your life. And the thing here is that these people were not trying to be happy. They weren't trying to have well-being. They weren't trying to live longer and be healthy. It just happened. And it happened because of where they lived and the lifestyle, to your earlier point, that they were able to live. And so if you really think about it, the reason we need lifestyle medicine is because we don't live in blue zones or blue zone-like. This is really a solution because of where society finds itself today. And so, and just to close, I sometimes I show a slide when I do presentations, and I'm a little bit provocative, and it's actually gotten me in trouble with some groups. But I say, remember when, and I pause, and I say, when Black people were thin. And I show pictures and photos from Time magazine, Life magazine back in the 1960s and the 1950s. And indeed, even Black people were thin. And so what has changed? Our genes haven't changed. It's that we are living in these food deserts. We're living where fast foods and party stores versus, access to real food. We're not able to live a lifestyle where we can get physical activity and things like that in the way that we should as a human organism. And so therefore we need lifestyle medicine. So it's a powerful solution. We need to have it because we don't all live in blue zones, but it's just something to keep in mind in terms of what is the root cause.
Beautiful. Thank you, Dexter. And David?
All right. So thank you. Again, Dr. Stoll, for inviting me. And I love the fact that we're having this conversation. I think it's well-timed. And so I'm glad that you're having this. So one of the things that I think about, and you touched on it before, is that a lot of times people think that the health problems that run their family are inevitable. That, it's just everybody in my family has heart disease, so I'm going to have heart disease. And really, the problem is less that heart disease runs in the family and more that nobody runs in the family. Nobody's exercising, nobody's eating right. That's typically more of the issue. And so when people get to understand that, it's like, I thought that just happens. No, you're eating the same food. You inherited your eating style from your parents. I mean, I ate a boatload of sugar growing up. And so right now I'm struggling to, not eat sugar. And so it became a major effort that I had to require spirituality to help. I couldn't do it in my flesh, right? So the second thing is, when COVID first started, when Fauci first said that Blacks and people with chronic diseases were doing worse with COVID, I perked up. I said, I know exactly what the problem is. That Blacks tend to have more psychological stress from just being Black in America. Just being Black in America, you're going to have more psychological stress. I had a white colleague of mine who we talked about. She was like, "Oh my God, the cops pulled me over, and I just could not believe it. I was so scared and so nervous that I was going to get a ticket." And I was like, "That's why you're upset? That's why you're nervous?" Like, when I get pulled over, I have a whole different fear. And so that psychological stress can lead to a physical stress, an oxidative stress. And almost all of our chronic diseases are based with oxidative stress. And so we start off with higher levels of oxidative stress by just being Black in this country, whether you have money or you don't have money, even more so if you don't. And so that kind of psychological stress and oxidative stress leads to the oxidative stress disorders. And that's where COVID was hitting, because COVID was hitting people who already had the high blood pressure, whether you're white, Asian, or whatever. If you already had those health issues, it's because those health conditions were associated with oxidative stress. And then all of a sudden now COVID comes in with a cytokine burst, cytokine storm, and then boom, you're in over your heads. And so really, when that happened, the light came on for me that's why Blacks were dying worse of COVID, because we had so much oxidative stress, so much psychological stress that we don't deal with. We don't deal with it. We don't, talk about certain things we don't discuss, certain things we don't go to counseling like we need to. Certain things that we just don't deal with. And then another thing I want to talk about was there was a really good documentary called Invisible Vegan. And in that documentary, they talked about the concept of nutricide. That, this is not genocide directly, but it's nutricide. It's like, how can we nutritionally kind of harm a community? And it goes back to what Dr. Williams was saying, that that there's certain areas that where it's almost designed to have fewer grocery stores, designed to have fewer health food stores, and designed to have more fast foods and liquor stores and and cigarette stores and vaping stores and stuff like that. It's designed that way because they kind of want that to happen. Because if they really wanted health in communities, it would be a whole different story. And so I think that having conversations like these where we can start to say, oh, that's the problem. I didn't think about that. Could be the start of a major change to say, how can we impact communities, not just with better grocery stores, what have you, but really a transformation in their minds about health. Because if you think about it, if I just, if I have better access to potato chips, because I have a grocery store now, that's not going to help. Like, you can have all the nice, pretty foods that are in the grocery aisles, but the people need to know, why is it important for me and my family to eat this? And what are healthier ways or quicker ways I can do this, or cheaper ways I can do this? So, maybe instead of going for the fresh berries, you go for the big bag of apples. I just did that recently with my at the grocery store. I got $8.99 thing of blueberries that it's not that big, and then I got it was $9 for the organic blueberries, and then for the big old bag of apples, literally 20 apples, it was $8. Then don't get the berries, get the apples. But if you say, oh my gosh, well, berries are the healthiest, so I have to get berries, then for you it seems as if it's really expensive. But if you think about it, beef costs more than beans, and chickpeas are cheaper than chicken. And so but people have to know and understand that these things are out there for them, and they could curry their chickpeas just like they curry their chicken. And so I think it's really multifactorial. We need the public health people. We need it'd be helpful to have some government intervention, and be helpful to have a lot of the churches get involved, because churches are a huge key in Black communities. We're talking about health disparities in general, but one of the biggest victims of health disparities are Black. So the church is a really big factor. And so, how can we get all these different players in the same room and say, we have a problem, let's fix it?
Wonderful. Thank you, David. And Columbus, thanks for being patient. You're the caboose, but I'll make you the engine next time.
No, listen, I enjoy listening to everyone, and I always learn, when I'm in the room with greatness. And I appreciate you so much, because, when you look at the concept of what you're doing right now, and we know that race is a social construct, we understand that. And I always share with folks that would mean then that health disparities are also a social construct, when the racial health disparities are a social construct. And so I'm a big believer in history. And I believe that it's important for people to understand, and it's not an issue of individuals being subjugated to circumstance. And people may say, well, why don't they just fix it? Why don't they just kind of do better? They know better, why don't they do better? But to understand that there is a systematic system of events that has transpired that's led to our current state. We understand that the answer to the healthcare crisis in America is a whole food plant-based diet. I think everyone on this panel will wholeheartedly agree with that. But I think it's also important to understand that there are certain things that have come into play, sort of political determinants of health, as Daniel Dawes outlines inside of his book, that have played a role from a construct of the system, whether or not it's housing and redlining, that has partitioned groups against one another and has led to the haves and have-nots, right? So the lack of housing that's happened historically with the inappropriate use of the GI Bill that partitions, right? That was a major player. You then move over and you understand that these zip codes now that were created, because we know zip codes are predictive of your health, they're also predictive of your education, predictive of your opportunities. And so we see the educational system that's diminished for a lot of individuals inside communities of color and of the BIPOC communities. And what's the result of this? Well, we do know that too, once again, that now this will impact your occupation. It impacts your ability to procure jobs and economic proclivity, right? So now I have housing that limits my economic growth and wealth is predictive of health outcomes. We know too as well that it's going to be predictive too as well of the education system too as well. And we understand some of the issues that have arisen that really led to that Dr. Bowman is at historically Black college and university in Howard, but we know that out of the Flexner report, many of the historically Black colleges and universities were disbanded, right? Coming out of it, as were other college, medical colleges too as well, that tremendously impacted the presence of individuals of color in the healthcare field. So these things impact access to care and that ability for people to bond. So we look at the combination of things, the economic, the education, the redlining, that now you have walkways. We say, well, why don't you walk a little bit more? Why don't you move a little bit more? But understanding that in many communities, you don't even have crosswalks. You don't even have lights inside of these disparate communities that are there. And that now, as a result, the businesses have been subjugated in a particular stance where now you don't have grocery stores and you have more fast food restaurants and liquor stores. And then we begin to wonder, as you have policing and others have brought up the role of stress that it plays in predictive of disease, and that studies have confirmed that racism is a form of a stressor. And we know that perceived stress predicts disease. So we see this vicious cycle that begins and it begets one another. And we know that stress leads to eating foods that are less ideal for the body, increasing visceral fat and the bioactive components that are there. And so now we have this cycle that just continues to inflame in this crucible of conflict, of stressors ignited by nutritional stress. And we have this explosion in health disparities, and we sit back in 2020 and wonder, why are we having this healthcare crisis? Why are we having this disparities as a result of COVID that's been there the whole entire time? And so that's why these things become important, that now when individuals, and this is important, so I'll share with you all. So I like Dr. Williams, I'm a cardiologist, I'm an interventional cardiologist. And so now when individuals seek care inside of community, inside of healthcare systems, they may not receive the ideal care. They may receive less ideal care in terms of revascularization or care. And I just experienced this firsthand. I brought a friend of the family who was African descent, who was having chest pain after COVID. They suffered with COVID. And so my mind immediately began to think, as they presented classic symptoms of exertional chest discomfort lasting for 6 hours that was increasing in intensity, I said they need to go and call 911 immediately. And they called, but were hesitant and shy to go in. I drove myself there to pick them up and drive them to the ER. I didn't have my badge on, didn't have my coat, didn't have anything of the sort. And as I arrived there at the ER, I saw how their symptoms were minimized, despite having chest discomfort, being of that age and where they're at increased risk. I saw how they were delayed in receiving an EKG. I saw how they were delayed in going back for an EKG, chest x-ray, as a cardiologist, as an interventional cardiologist. I saw it really happen. I had never really seen it happen to myself or someone that I know in my life. And so now it became manifest. And I see the problem that's there, that's this implicit bias. And so we see this cycle that then leads to mistrust of the system. That now this stress that leads me to now I don't smoke, I don't drink, but I eat my food. That's socially acceptable, and that is government subsidized to make it affordable for me. And that now I can purchase five burgers and French fries for $5. And so there's a great need for us to make a change, and the change has to happen at the grassroots level, But in the words of Daniel Dawes, it has to happen as well on the macro level, at the governmental level. And we see this even transpiring when we're looking at the transportation that's being proposed and the revisiting of that through Buttigieg and Biden, and trying to look and revamp some of the things that have been done where transportation is really dissected and cross communities of color. We're intentionally built inside, destroying homes, displacing over 500,000 persons of color when the time many of the constructions were happening. And so this is such an important topic. It's such an important topic from a historical standpoint. You know, as a physician, I'll end on this. As a physician, one of the things that we start off by doing is we assess the burden of the symptoms, what's transpiring with that person. We then turn to the past medical history, the past social history. We then turn to the family history, and we try and understand that will shape our perspective on what's the impact on this person and their life and their offspring. And so I think we have to take that same thing from a societal standpoint. It's imperative that we look at the history to understand how we got here, so we can understand how to prevent ourselves from coming back here in the future and to really address the issues. So thank you all for allowing me to be a part of this conversation.
Wow, thanks. Thank you, Columbus. That was such a cogent elucidation of the roots of the problem. And I love the idea of going back to the history. That's, it's through the lens of the history that we can understand the context of the present. And you're absolutely right. That my second part of the kind of this evening was to look at the roots. And you just you went right to the roots of the problem. And so I think what I'll do is just ask for anybody else that would like to just add to what Columbus said about the roots of the problem, and then we'll make a quick transition to solutions. Talk about what you all are doing and maybe how we can inspire people that are watching us to get involved. So first, anyone else want to add what Columbus said when he talked about the roots? You can raise your hand or just jump in. I think you might have nailed it, Columbus.
He nailed it. He absolutely nailed it. I don't know how much more can be said about that. He absolutely nailed it. That was a great spiel. That was just powerful.
And the good news is we recorded that. So we're going to package that and send that out, because that, honestly, Columbus, that is one of the most succinct, coherent descriptions of the problem I've ever heard. And so I just really want to thank you. That was inspired tonight.
Yeah, I would agree. You hit the nail on the head. Excellent. And what it reminds me of is, how do you make change? And one of the ways that we have seen, going back looking at history, you make change is that you start a movement.
Yep.
Yeah. And there's a UAW phrase where they say you have to educate, you have to educate, you have to advocate, and then you have to agitate. And so, I think that, Columbus, you have really sparked something for us that calls for a movement, and people need to understand what's happening to them. And I think if enough people get up in arms, so to speak, and say, I'm tired of this, and I don't want to be like this, that we can start to make a change. And I think it has to happen at the grassroots. And I think we have a job to sort of do those three things that I mentioned, to actually start that kind of movement. And I think that's where we might get some momentum. But I don't think, and I hate to say that, we're all physicians on this call, but I don't think it's going to come from medicine. I think it's going to come from somebody else, because medicine is just what it is, and reimbursement systems are where they are, and they don't see this oftentimes as their job. They don't get reimbursed for it. So I think we have to look elsewhere. And Scott, part of what you're doing is that. So thank you.
Yeah, thank you.
I would just add that I'm hoping that Dr. Batiste will share his slave food podcast link with everyone.
Yeah, that's great. Let's do that. We'll put that in the chat, and then we'll attach it to this seminar when it goes out by email.
Great.
Thanks, Kim.
Appreciate that. I will say this about the slave food, just so for clarity for those, because everyone's of different, everyone wants what's best for humankind. That's either participating on this call and so forth. And so one of the most interesting things about the slave food, which is a double entendre, it obviously addresses historical figure aspects, but it really speaks to the fact that people oftentimes are enslaved to their environment, that sometimes they're subjugated, that they feel like there's no choice, no option around them because of finances, because of the environment and so forth. And so I always kind of joke and tell a brief story about how I gave a talk around the content of that. And I had a Caucasian man from the Deep South who reached out to me as a result of hearing it. And he made tremendous changes with his lifestyle. And he lost 50 pounds in a matter of like 4 months. Diabetes, of course, not surprising to anyone, vanished away, blood pressure lowered. And he is a lover of eating whole food, plant-based, despite everyone around him still eating the Southern style diet. And he's a strong advocate. He's like, whatever I can do. I said, just each one teach one. That's all you have to do. So.
Well said.
Yeah, well said. Thank you, Columbus. Well, let's kind of turn the turret now and let's look at solutions. I would love to, each of you are actively involved in solutions. My wife and I started an outreach 4 years ago, kind of discipling an inner city, Allentown, Pennsylvania. We just saw a need. And so we actually just started by going to a food bank. We bought 400 pounds of fresh produce. We opened up a table on the corner of a street. It's actually called Liberty Street, downtown Allentown. We started giving away food and meeting people. We were invited by a church to use their parking lot, which we had passed for weeks and prayed that we'd have an opportunity to use it. And they gave us the parking lot right in the middle of the inner city. And so now we give away 20,000 pounds a week to the same kind of neighborhood in the city and partnered with people. And, we believe so many of the food outreaches, they give people a number. We wanted to give people a name, so we put name tags on them so we would get to know them. We set up, instead of boxes, we set up a farmer's market to give people the opportunity to choose food, to learn about food, to have conversations. And so in the last 4 years, we've given away 750,000 pounds of organic produce and are just really working on discipling an inner city. We did that in Pennsylvania. Now we live in Tennessee, and so we're going to, look to start that here. And then, I'm working in Jamaica with another group. 40 churches. We just got an acre of land. We're going to start growing food on this piece of land, giving the food away, using that food as a resource for farmers markets and educating through the church to begin reaching people as well. So it's all of us can find somewhere where we're connected that we can start reaching out and making a difference. So Columbus, you were last, so I'm going to make you first. So please share with us, I don't want to give it away, but what you're doing, because it's such a unique, it's a unique endeavor.
Yeah, no, thank you. So I started a nonprofit, co-founded a nonprofit several years ago called Healthy Heart Nation. And essentially it's addressing the pillars of social determinants of health with a justice arm, an education arm, a business arm, and a health arm, with the initiatives to provide access. So we're going into barbershops and actually trying to physically provide blood pressures to stay inside the barbershops that's there for them to use on a regular basis, along with education on nutrition and lifestyle there too as well. Providing events, one of the big sponsor type events that we do that Dr. Williams already alluded to, and I'm waiting to have the rest, two out of the five of you have been on, and we'll have to get the rest of you on here too as well. But we had Dr. Shurney and Dr. Williams on before, but Slave Food Project, and so that's it's a conversation that I have where we discuss really the role of stress, discrimination, and nutritional stress in the formation of health disparities, and how the real solution towards the problem ends up being in resiliency. And that resiliency, at the heart of resiliency, is nutrition, through nutritional resiliency, through our foods, a whole food plant-based diet, but also through mind, body, and spirit, and looking holistically, right? So we understand that there are more that comes into play with a person's being than just on the table. And so trying to address those aspects. And so bringing in experts and having pertinent conversations that are relevant for communities of color, that are applicable to everyone. I always share the story that whenever I address a topic that may seem as if it's targeted towards race, I tell people it's almost like a superhero movie. You have Superman, you have Batman, you have all these different folks, and there's always a good guy versus a bad guy. In the end, hopefully the good guy wins, right? But it's all shaped and it's crafted differently. Different storyline, same theme. And so the same theme is the same. The whole food plant-based diet is the answer, but this construct surrounding it is really as it relates to that. So that's what I'm doing. Personally working with churches. The goal is to try and get gardens. So I applaud what you're doing. That's phenomenal. Like minds think, come together. Is to try and get gardens inside churches to partition some of the parking lot structures, to give scholarships for individuals who are really suffering to be able to go to lifestyle retreats, to be able to, and who are not unable to afford it, who need more aggressive type care. So that's what we're working on, fundraising. And then of course, I plan on meeting with you, so I have another idea for a big event that I'll loop in everyone on this this call as well in the future, hoping to put on at some HBCUs and some other sites. So that's in a nutshell, briefly, what I'm doing right now.
Fantastic. Thanks, Columbus. David, you're next.
All right, good. So a couple things that I have been involved in. One, I think Dr. Batiste mentioned this earlier, that I work at Howard University, which is a historically Black college and university. And as such, we're one of the nation's leading providers or producers of Black medical students or students who are racial minorities. And so so at the university, I have kind of undertaken the task of being the clinical nutrition specialist, if you will. And so I train all the residents, all the medical students who come through. They come through on my department, and I train them on clinical nutrition and talk about the power of food as medicine. So trying to get the people at my HBCU medical school to try and understand about the power of medicine. And they ask me a lot of questions, and we talk a lot about, almost every time we have a chance, we talk about how we can change the way we approach medicine to all the medical students who come through here. So it's like, okay, so this patient has constipation. Let's talk about their diet. This patient has eczema. Let's talk about their diet. Eczema, right? And so we talk about that. I also do an intern wellness day for the residents. We don't have a residency program, a pediatric residency program at Howard, but we do have access to the residents that way. So I do a wellness day for the residents. On my spare time, my ample spare time, my wife and I run what's called Lifestyle Med Revolution, and we do a lot of we sponsor a lot of Daniel fasts, where we go with friends, family, whoever have reached out to me, and we do Daniel fasts to talk about really transforming our mind. Because really, if we think about it, it's being transformed by the renewing of our mind towards what food is. Most people think of food as just something that I do, or it tastes good, or it's just, but to really transform minds, to say, this is a source of healing. It's a source if they go back to the first chapter of the Bible, where, God talked about, we're supposed to have dominion over animals, but for food, it's herbs and plants. And so to get people to be empowered this way, and then kind of branching out from there. And so I've talked with churches. I've a few churches in the DMV, that district, Maryland and Virginia area, about doing the same thing and trying to get their parishioners to really get involved in that. So that's in a nutshell. I know we're short on time, so I want to make sure I give everybody else some time to talk about their thing. But that's a few of the things that I'm involved in.
Thank you, David. Yeah, and we're going to go till 8:10 or so. So we have a good 15 minutes, and then we'll take some Q&A. But I want to make sure that everybody has a chance. So thank you, David. Churches are such a key solution that has been essentially untapped. So I really appreciate you bringing that up. Let's see, Dexter.
Columbus and David, they're so eloquent with their words. I feel like I'm following, Michael Eric Dyson and Muhammad Ali here, So, I love the way these guys have a way of putting their thoughts across. So thank you for that. Just a couple of things that I'm involved in, and Scott knows some of this, is that, I always say that to make this sustainable, you have to follow the money. And it just gets people to behave differently. And by that, I mean the payers and, the powers that be, so to speak. And so I'm involved in a couple of things: food as medicine, randomized control trials, where we're actually looking at claims data, pharmaceutical as well as medical claims data, to see if we can really make an impact on those data. We do that short term as well as long term. And the idea here is, and we're working with some large insurers to do this. So the goal is, if we're able to pull this off, and I think we will be able to, then the concept is to build food as medicine into the benefit design. So when you have a health plan and a benefit design, food as medicine will be there, just like a generic drug is on the formulary. And so while we have PBMs that look at drugs, we would also have this in part of the step therapy. It would be something that patients, would be part of their protocol in that step therapy. Now, again, you can't get everybody to do this, and just like you can't get everyone to be adherent to the medications we prescribe anyway. But at least this would be part of the conversation, part of the dialogue, part of the education that every patient would have with that benefit design and those opportunities. And then the benefit design would also help to get the patients access to that food that was prescribed. So they wouldn't be left on their own with the prescription and no means of fulfilling that, but they would also have the wherewithal to get the food as well. So that's one. The other that Scott's been helping me with is a lifestyle medicine focused practice. This is the concept of primary care physicians with inside health systems being able to refer to a specialty practice of sorts that's lifestyle medicine. Just like they would refer to, Columbus or Kim, to have cardiology care. Here they would be, referred to a lifestyle medicine practice that really has the resources, coaches, pharmacists, whatever it is they need, food kitchens, teaching kitchens, all that kind of stuff, as well as this benefit design around food as medicine to really work with that patient. And the reimbursement model would be a bundled payment. So they're not worried about how many, group visits I have to do in order to make my bills at the end of the month. If you want to do group visits, you do it. You got the bundle. You do whatever you think that patient needs. You can personalize it to however you need. Some patients might need more, coaching on sleep, and others might need more coaching on how to move or tobacco cessation. But all of those lifestyle medicine levers would be in that bundle, and you as a physician and your team figure out how to do that. And on top of the bundle, you would be paid for things such as moving the biometrics to show that you have, move A1C a certain amount, and you get a bonus for that. So you get incentives for doing the right thing that all of us know that this is what we're really trying to do. If you reduce medications, so a patient's on, 12 meds and they come down to 6, good for you. You get a bonus on top of that. And guess what? I now have the savings to pay that bonus because they're not taking as many medications. And to David's point, a lot of these medications are due to oxidative kinds of things and anti-inflammatory issues. And so some of those drugs are very expensive, the Imbrols and the Hamiras, thousands of dollars. And so, even if you move just a percentage of the population, there's great savings to be had to pay the physicians back for that good work. And then the capstone is that if you reverse the disease, you get even more of a bonus because, again, there's more savings. And if you can maintain that patient at that reverse level, I'm going to pay you in year 2 and year 3, et cetera, for maintaining that, because there's a savings back to the system. So those are some things that I'm working on, again, using this reimbursement lens, because I think, we need a movement at the patient level, but we also need a movement probably more financial in terms of self-insured employers and others saying, yeah, I'm tired of my, pricing going up, millions of dollars every year, and my people are sicker. So those are some of the things that I see as potential solutions. Keep your fingers crossed, David, pray for me, that we get the right results and the people will understand the value.
Beautiful. Thanks, Dexter. Kim?
Well, thank you. These are wonderful ideas, and they are all going to this obviously the social determinants of health and the impact that nutrition can have on so many of them are so multifactorial. It's interesting to hear everyone's approach. I would actually do two things that I value. One would be clinical research like Dexter's doing, where we do the food interventions and do the biochemical approach. We need to do larger studies and popularize them more, show the people that their risk factors can be assuaged, improved, reversed, and keep that message going. I have been working with churches for screening and some intervention, but I think every public-facing opportunity that we have in our community, whether it's the barbershops that have been mentioned, the nail salons, going into the dental offices, which is our drilling down on hypertension program. And people say, why would you go into a dental office? Everyone's afraid. Well, there's good data that if you have an office hypertension, your 5-year incidence of hypertension becomes highly substantial. And so identifying people whose blood pressure is elevated then, who aren't aware of it, it's an opportunity for early intervention. So, and for monitoring. The concept is that knowledge is power, and doing all the screenings that we can with our, lipid testing and diabetes testing and blood pressure, plug it into our ASCVD risk calculator, which, by the way, anyone who's listening can download. That's from the American College of Cardiology. That risk calculator does have African-American race in there, which the other, like the Framingham risk never did. And so we're able to use that in a population that's vulnerable and try to tell people what their risk is and get them to come in and be managed early. So that really is our approach. I would love to be able to do much more in the way of nutrition intervention and nutrition education. And maybe with all the people on the call, we can do some of these things together, because being able to identify the diseases early, the risk factors early, tell people that they're at risk, and then not doing much about it is certainly hollow.
Yeah, absolutely right, Kim. And to your point, the solution comes through collaboration. And so collaboration is absolutely a key to this, to solving this injustice. And so I agree with you. The more that we can have conversations, grow awareness, develop relationships, and then begin collaborating on solutions, the more rapidly we'll see, people set free from the position that they're in. So thank you for bringing that up. Margarete, thank you for waiting so patiently. I'd love to hear what you're doing, internationally and nationally as well, because I know you're involved in a lot of very interesting projects.
Thank you. It's been fantastic to hear so many of the thoughts on this call, and I really agree that starting with collaboration is a fantastic place to start with solutions as well. Can you hear me okay?
Yes, we sure do.
Okay, great. I do want to again echo what Dexter Shurney said, in that I think it's a great little way to look at it, that education, advocacy, and agitation. And there are some things that I'm doing, and I'd love to talk about them, but you've got 5 people on the call. We're all used to talking for an hour, so there's that was a dangerous thing, but a wonderful thing, so powerful. I would like to briefly speak to that, though, in general, that in education it's imperative, it's not even optional, it's imperative that we have good nutrition teaching in medical schools, in residencies. I know that Loma Linda is at the forefront and with the lifestyle medicine residency curriculum. But also, I think that, as has been mentioned, we need to meet people where they are, where we are, in the grocery stores, in the dentists, in the barber shops, in the nail salons, in churches, all of these avenues. And one of the really powerful things of this course is that it shows all of these levels, looking at a large corporate financial level, looking at advocacy on a national level, looking at advocacy on a local level as well, looking at distributing food, looking at food gardens, and that's another thing which we're involved in at Loma Linda, that we work with a very underserved population in San Bernardino, and have a community garden there, which our residents are also involved in, so that it's an opportunity to really be. Because I think that just to start with the listening is incredibly important, rather than running in with our solutions that we statistically know can work. If we actually listen to our patients and we listen to our communities, that's a very powerful first step. And I also wanted to say that we need to start with children. It's incredibly, they are our future, quite literally. And I think that as we come through, hopefully through this COVID time, looking to the children, looking at decreasing their risk factors of non-communicable disease, and looking at how they can be masters of their own destiny and really advocating for them. I wanted to give a shout out to New York and what's happening in New York City, where they're actually incorporating whole food plant-based diets into the school lunches, because I think that as we teach our children good nutrition, then that is going to hopefully start incrementally to change the culture in so many ways. And that is one thing for all the people listening on the call. You've had amazing examples of advocacy at work, on all of these different levels. But if we can do one practical thing today or tomorrow, it is to have a family meal together and to teach your children and walk by example. So I just did want to say that I am involved, yes, on an international level. I'm very passionate about the Lifestyle Medicine Global Alliance, which is physicians from now over 40 countries who are passionate about lifestyle medicine and looking at good nutrition. And that covers a lot of the blue zones as well. There are many ways to advocate because there are also many challenges, and in each country it's different, but coming together and talking about the solutions again means that we're able to set best practices and also develop communities of practice. And as Dr. Williams was saying, that getting research and getting the power of diverse multi-center research is really important, and I think that we have the opportunity to do that internationally as well as nationally. And then again, on a local level, working with medical students, working with residents, working with your local churches, and working in schools, all of those are really important. There is a lot going on. I want to be very respectful of everybody's time, and so I'm not going to go into too much to what I particularly am doing, but I wanted to just say that there is so much. And yes, I would be happy to talk more, but I think the most powerful thing would be just if everybody on this call can make that one commitment to just do as Columbus said, to just, I think it was Columbus, there's been so many eloquent people on the call, to just make one change and touch one life, then that's already going to propagate to the beginning of this tidal wave of movement, which not only will happen, but has to happen.
Wow, thank you. Thank you, Margarete, for making it so elegant and so simple. You're absolutely right. Change begins with a conversation. That's what I always say. And good conversation involves a lot of listening. I always teach my children that a good conversation is like a tennis match. You got to hit the ball Kimmel like that, back and forth. It's not a golf game. and it involves a lot of listening. So I really appreciate that. And the more that we can have conversations with people, with communities, we gain awareness. It stirs up a heart of compassion inside of us so that we end up being moved by compassion. And that's a powerful place to be moved from. We see a fellow brother or sister in need, and we're moved with compassion to begin stepping in and helping to bring resolution to an injustice. So thank you for that. Are you all okay staying about 10 more minutes for some questions? All right. So we have a few questions, and maybe what I'll do is I'll ask the question. If you want to answer, just raise your hand, and we'll just try to get through, half a dozen of these in the next 10 minutes, because we've had such a wonderful group following us this evening. First question is a good one. Any suggestions how I can get my congressman to hear this information? I've contacted the office several occasions on some food-related issues. I've not yet heard back. Any thoughts on how to make that connection?
I'll take that to start with. The American College of Lifestyle Medicine actually works with a lobbying group, Alston and Berg, outside of, they work out of Washington, D.C. on Capitol Hill. And so I would suggest getting in touch with ACLM and become a part of that. We're going to Capitol Hill routinely now and having those conversations.
Great, thank you. Next question. This is maybe for David, for Columbus. I found some parishioners to be the most resistant folks to making food changes, as they believe God will heal them and the Bible doesn't outlaw meat or dairy as a sinful thing. What are some successful methods that you have had using to break through these arguments and influence change?
I can take that one.
Yeah, thanks, David.
Yeah, so a couple things. One is that doing a Daniel fast is a great way to do it. We're bringing it straight spiritually from the Bible, doing a Daniel fast. The second thing, there's a lot of quotes I can look at, and the way I look at the Bible a little differently as it relates to health. If we think about the power, there's a scripture that says the power of life and death are in the tongue. And we usually think about that in terms of how it relates to what we say. So if I say, I can't stop eating this, I can't stop eating that, that's a problem, right? But the power of life and death is in the tongue. Wait a minute. It's also the tongue is choosing my food. So if my tongue is choosing the food, then the tongue has power of life or death. Right? And so my tongue is choosing foods that can create life or create health, or my tongue can choose foods that will create death and disease. And so let's look at what foods cause death and disease. And so we go into that tremendously. And then, talking about just going back to the very first chapter of the Bible. The very first chapter of the Bible, it talks about eating plants. And yes, we can't eat foods, but the question is, and there's nothing wrong with eating food, eating meat. There's nothing wrong with it. It just leads to an outcome. And let's look at the outcomes that are there. So I'm not, vilifying, eating meat, like don't eat meat. I'm not a plant-based person based on not eating animals. Like animal cruelty that's not where I'm at. Some people are, and I respect that. Where I am is, what's it doing to your health? And this is your temple. If I have a temple, if I have a church, I'm not gonna want people to smoke in the church or to trash the church. And so similarly, if my body is a temple, I should treat it as really, as really healthy. And so let's talk about that. But to me, it is some parishioners are very difficult to deal with, not difficult to deal with, difficult to convince. And that's okay. We can have that dialogue. And some people are going to be resistant. But there are a lot of people who are open. And so I don't want to, not do certain things, because I know there are going to be some people who are resistant. Let's go ahead to the ones who are open. As one, but two, also bring in spirituality and say, let's do a Daniel fast together and see how you feel.
Brilliant. Thank you, David. Kim.
So thank you. I actually have a very strong affiliation with the churches and the Christian upbringing in the South Side of Chicago, and so I can actually relate to people. And I will bring them the scriptures, and I know it's been Dr. Bowman mentioned a couple of them that I typically would use. I do mention the fact that the original design for your body, and that's described in Genesis, you're supposed to eat the seeds and everything, every tree that bears fruit, and that will be for your meat, Genesis 1:29. And then I tell them, if you have a problem, you don't believe what your cardiologist is saying, you do have a problem. But if you don't believe the word of God, you got a much bigger problem. So, and I have been known to, hijack scripture. They say this when I went to, seminary for probably 8 years. They used to say, if you take the text, if you take the text out of the context, all you're left with is a con. So maybe just a little guilty here, but I quote 1 Corinthians 6:19. That is, you are the temple of the Holy Spirit, as Dr. Bowman said. And but the rest of that scripture actually says you are not your own. You have to make decisions as if you're reporting to someone who is superior to you because you are. The last one I use for people of the Christian faith is just Matthew 28:20. I mean, that's the Great Commission. And I tell you, you can't go into the world and create disciples if you're sick or dead. You just can't do it. So anyway, that does resonate with people. I have gotten people to reconsider, people of faith to reconsider how they're living and make some lifestyle choices that are going to be more healthy.
Wonderful. Thanks, Kim. And Columbus?
Yeah, I recently gave a talk to a church just the other day, and I do it frequently as well. And, one of the things that I brought out to them specifically is that, when you're looking at the church in general is really, it's aging, and there's people who are leaving the church on a global basis, and our church population is aging. And when we look at the aged population, we're seeing the burden of chronic disease. And so I speak to them in very practical terms. And the fact that it's not the number, it's not the many, it's a few, but strong. And so we have to be strong in body, strong in mind, strong in spirit in order to fight, in order to stand up for what we believe, because the purpose of health is not to be healthy. The purpose of health is to live a life of purpose, right? And so how can you truly live a life of purpose if you're sick and ill? And so as I begin that process of discussing with them of how you feel, you don't feel like being compassionate, of empathizing with people when you're hurting. And so it's important that we have strong bodies and minds to match in terms of what our purpose and our goal is in life at the end of the day. And so I too, like Kim, I've been known to hijack a scripture and give a little mini, I call them lectures, not sermons, but reconfigure things with an intention. And it tends to be received, but at the end of the day, people are people, and we have to show them. They need to see it. And they're more inclined to be receptive of a sermon that they see than one that they hear on a regular basis.
Yeah.
Scott, I would, if I can just add to that as well, because I hijack scripture too, for the right purpose. And it is true that the Lord is all powerful. The Lord is the great, God is the great physician, and he can heal us. But it's also like sin. The Bible tells us that, if you don't know better, the Lord kind of winks at sin because you don't know better, right? And there's a quote in James, I think it's James 4:17, that says, "To him that knoweth to do good and doeth it not, to him it is sin." And so you don't want to, God will not be mocked. And so if you know to do better, then that's a little different than if you're doing things and asking for forgiveness because you don't know better. And so, there are a lot of things that we can point to that sort of have that application.
Wonderful. This is such a great conversation. We can go so deep. We'll take maybe one more question. We have so many good questions. What I'm seeing is we've got to do this again. In some way, we've got to take this to another level. This conversation is so important and so rich, and you all have so much wisdom. that this can't be the end, it's just the beginning. So here's a really good question, and we can maybe wrap around this, the food deserts. Is there a concerted effort to connect with Black or other farmers to establish grocery stores or community food resources in these food deserts? I know their community gardens are common, but they aren't everywhere. Do you all have any ideas on how to start integrating agriculture into the inner city?
So I'll chime in. So not that I have firsthand knowledge and that I have personally done it, but there's a lot of individuals, there's a lot of work being done for urban gardens that's happening on a regular basis. I actually stumbled on one as part of surveying an area. I grew up in South Central Los Angeles. And so literally around the corner, someone developed out of a church parking lot, large farms called Alma Farms. And it's very proactive, and people come and it's free, and they're able to, or there's a nominal fee for it. They can come and they can tend to the plants, learn how to grow and feel, and students coming through. And so it just takes an effort. You spoke about the individual inside of, or Kim, you spoke about the individual, I believe, inside of Louisville, and I'm blanking on her name right now, who really coined the term food apartheid, and really her work with developing urban gardens. And so it really just takes a little bit, as Margarete mentioned, whatever that one thing you focus on, if this is the one thing you focus on to start, and finding a patch of grass, even if it's in front of your lawn, and say, I'm gonna start to grow something, that could be powerful and begin a movement in your particular neck of the woods. Obviously, there's zoning laws and all the other issues like that, that people will fight and so forth. But there are plentiful amounts of resources and individuals who have been successful in implementing this in urban settings. I think that's where it starts and can grow from there.
And sorry, go ahead.
Oh, sorry. I want to say, so beautifully said, and I think that there is two things. One is there's a top-down approach. There are a lot of both urban and also now regional and ultimately federal government programs which are supportive, specifically of gardens, although that's not the only way I think that we can get people eating more healthily. But then there's also, as Dr. Columbus was just saying, that the grassroots is so powerful. And even if that means just getting some sprouts and putting them on your kitchen counter and starting with your own kids, and then talking about it at school, or then talking about it at Sunday school, or talking about it at church, talking about it in the synagogue, talking about it at work, that top down and the bottom up together are really, really powerful. And the reason of that gardens are so successful are really because it is mind, body, and spirit. You get to really experience the beauty of growth. And it's well shown that even if you just get your kids to help cut up the vegetables for dinner, they are going to think that that soup is delicious, even if they've said no to exactly the same vegetable soup the week before. So getting people involved. I love your question that it's about urban gardens. There's a top down, there's a bottom up, and just start small and find your people. There's food policy groups. There will be pretty much wherever you are here in the United States will be a food policy group. As Dr. Shurney said, the American College of Lifestyle Medicine has some great resources, and look also to your to groups which may already be there with urban gardens, and then also to your regulatory groups, your government. Thanks.
Let's just give a slightly different perspective. When I was in Detroit a few years ago, there was a movement to take so many areas where a building had been, condemned or removed, and to try to make an urban garden there. And it was fairly successful. And I was thinking about that. I was speaking with one of my buddies who you all know, my partner in church nutrition intervention, Dr. Terry Mason. And Terry said, "No, that's really not the way you want to go." That he's going into the rural community, making much more land, first of all, and a much more variety of produce. And then instead of doing the urban farming, he's bringing it from rural to the urban area. It's just a few miles outside of Chicago. And that is something that a lot of urban areas are surrounded by fertile ground. And with a little bit of transportation, a little bit of organization, you could pull a Terry Mason and actually feed people really healthy food and supplement the deficiencies that we have in our corner stores. I hadn't thought about that before.
No, that's great. You know, Rodale Institute, we're doing a project with Rodale, the Regenerative Health Institute, and they kind of flipped the CSA on its head, and they have, agricultural supported communities. So they went to inner cities, and instead of, community supported agriculture, they went into the inner cities, partnered with people to come out on the farm and participate in the agriculture. And so in that way, they're connecting, inner cities with the farm, which is a really beautiful dynamic, and farmers and growing food, and kids are pulling carrots out of the ground. They didn't know carrots grew in the ground. So I think there's a lot of fun opportunities that we need to look at, rather than just going back to some of the tried and true things that really have not maybe resulted in lasting change. Hey, Columbus, there's one question for you about amiodarone. And the question was, what is the medication amiodarone used for in heart health? Is it safe? And are there any alternatives? So maybe just generally, without, we can't give specific answers, but just generally answering that for someone.
Yeah, and I'm hesitant to take over for the Dr. Kim Williams as it relates to cardiac questions. But in general terms, what I would tell you is that there are different indications for different medications. And the way that I would approach it generally when I give general recommendations to patients is to first to inquire, what is this medication being used for in terms of the condition? So you clearly understand that. I think it's important to understand, is it something that is helping me live longer or helping me feel better? Right? Those are important, simplistic concepts to understand as you address it with your provider. I think second, the next level of question there at that point in time is that really what happens if I don't take it, good or bad? So in that way, it allows you to make the most informed decision for yourself. But in terms of, is there a nutritional replacement for amiodarone? I think I can say fairly clearly the answer to that is no, but I'm not, but contextually, I have suspicions about what is being prescribed to you for, but I don't want to jump into that. But Dr. Williams, do you want to add?
Yeah, I would just add that we keep that in our pocket as one of our most powerful medications. Obviously, we always are in concern. Just I'm sure the person who asked the question has looked it up and knows that there are thyroid issues and there are lung issues that occur occasionally, things in deposits around the eyes. So why would we use a drug that has such side effects? Because it's amazing. That's why. And so we can be in a lot of trouble with rhythm disturbances of wide variety, and amiodarone will bail us out. In terms of alternative drugs, the dronedarone was really a disaster probably a decade ago, and it caused so many more problems, didn't solve anything, didn't have the big iodine load, but it had everything else. So I would say that just please talk with your physician and have that good conversation and make sure that you're into that area where this is the drug, that the risk is here, but the benefit is so big that it's worth taking.
Great, thank you very much. And so we've come to the bottom of the hour, and I just want to thank you, Dexter, Kim, Margarete, David, Columbus. I thank you so much for your brilliant leadership. I thank you for your courageous leadership within the lifestyle medicine space and as physicians. Thank you for your incredible compassion, the depths of your wisdom that you shared tonight, and most of all, for your friendship. It's because of you and that I have hope. It's because of you that even after tonight, and I hope I'm speaking for everyone that was watching, like the heart of compassion is stirred up more within me for, this injustice and to seek out solutions and see how I can participate even in the local community. So I'm thankful for that, and thankful for the way that you have framed the information tonight in such a proactive and meaningful way. And I just want to thank you all for your time and friendship this evening. So thanks for joining us.
Thank
And
you.
and to all, go ahead, Kim.
I was just saying thank you. Thank you for having us.
Oh,
Thank you
you're
for
welcome.
organizing.
Yes, thank you.
Thank you so much.
Yeah, and for all of you that joined us this evening, we thank you. Thank you from the Planned Nutrition Project. I want to thank Tom Dunham. I want to thank my wife who's watching tonight, and it's because of her inspiration that we started the project in the inner city. It's her heart of compassion. I want to thank our board of directors, and I want to thank you all for spending an hour and a half with us this evening for on a very important topic, and I hope that it's inspired you to begin exploring your inner city, as Margarete said, to start having conversations and listening, allowing your heart to move you as well as your head. And as a physician or a healthcare practitioner or a citizen, using your sphere of influence to begin making a change. Because as it's been said this evening, as we begin stepping out and at least meeting the need of a brother or sister, if it's just one and then that person meets the need of another and somebody's inspired by what we're doing, change can spread rapidly at the grassroots level. And so I want to encourage you that, as Stephen Covey said, to learn and not to do is not to learn. To know and not to do is not to know. And Maya Angelou said, I did then what I knew how to do, but now that I know better, I do better. And so it's my sincere desire that tonight, as you gained more awareness and education, that we'll all know better and will do better. So thanks very much, everyone. God bless you. Have a great evening.